Thank you, Raju. I'll be talking about approach to epiretinal membranes. It was first described by Vanoff in 1865. 2% of the patient above the age of 50 will have epiretinal membrane, and as the age increases, it becomes 20%. Bilateral involvement occurs in 10 to 20% of the patient, and if you look at the Beaver Dam study, which is an OCT-based study, suggested higher prevalence of epiretinal membrane that was at the range of 34.5, 34%. Uh, in 2016, preferred practice guidelines of epiretinal membrane over a period of 5 years. This is very important because 29% of the patient progressed, 26% of the patient regressed, and 39% remained stable. So the patient who were eligible for treatment was only one third. So any patient who comes to you with decreased vision because an epiretinal membrane, don't directly go in and advise surgery. Please observe for at least 2 to 3 months and then go ahead for a treatment in these patients. It's an idiopathic condition, can occur after RD surgery, non-proliferative retinovascular disorders, inflammatory disease, trauma, and after cryopexy and photocoagulation. It usually presents as asymptomatic in majority of cases. 5% of the patient will have vision less than 660. There is a reduced vision and a metamorphopsia. If you look at the signs, you will see a mild sheen on the posterior pole. There will be a vascular tortuosity and a straightening of paramacular vessels. In advanced cases, you will have a stria or a heterotropia of macula, intraretinal hemorrhages, cystic changes in the macula, pseudo holes, and PVD in 75% of the patient. The most useful investigation at the moment is ocular coherence tomography, which helps us to diagnose whether it's epiretinal membrane. FA is now usually we don't do FA for epiretinal membranes. Uh, Coming to the treatment, asymptomatic epiretinal membrane with good visual acuity, no treatment is required. If the patient is vision is decreased, patient is symptomatic. That means if the vision is less than 624, metamorphopsia, if there is a thick epiretinal membrane, and if you can document a sequential decrease in vision, then it will require a pars plana vitrectomy with an epiretinal membrane removal. Uh, you see this patient here, there is a large epiretinal membrane and you can see a loss of foveal contour in this patient. We took this patient for surgery and first a total pars plana vitrectomy is done. You can see a large epiretinal membrane and I use a 25 gauge MVR to create an edge. The process of creating an edge is the most important thing while doing an epiretinal membrane surgery. It's something like a cellophane retinopathy or the membrane which is stuck onto the retina. So if you can create an edge, then the peeling becomes easier. Whenever you are doing a peeling, always go towards the base and don't pull anterior posterior. If you pull anterior and posterior, you are liable to create breaks. And any doubt, you go ahead and stain. Like in this patient, I have done an BVG staining, which gives a negative staining. And I'm going towards the base of the epiretinal membrane, and you have to pull the membrane tangentially. Don't pull anterior posteriorly. And this membrane is removed and you can see that this membrane is removed totally. A slight area of membrane is left. I lost the membrane, so I use a diamond scraper to create an edge, and now you can see whole of the membrane comes in toto. These are the post-op results. This patient improved from 636 to 618. This is another patient post VR surgery, post silicone oil. You can see the laser marks here. And since the membrane we couldn't identify, so what we have done after a fluid air exchange, we have put an reti blue dye, and with the help of an 25 gauge MVR, the edge of the membrane is created. And once you have created the edge, then the membrane is peeled. You don't have to, in doubt, you don't pull the membrane, because if you, any time you feel the resistance is too high, please don't pull it, because you will create an iatrogenic breaks. And you can see whole of the membrane has come out in toto. And this patient improved from 660 to 612 vision. Uh, the results, improvement in visual acuity occurs by 2 lines in 74% of cases. No improvement occurs in 24% of cases. Better results were seen in idiopathic epiretinal membranes. Now, there is another controversy whether to peel an internal limiting membrane with an epiretinal membrane. Liu et al. Performed a meta-analysis of ERM surgery with and without ILM peeling. Patient who underwent ILM peeling had better visual acuity at 12 months, but by 18 months, no significant difference in both the groups occurred. Microperimetry showed better results in non-ILM peeling group as compared to epiretinal membrane. So as a preference, I don't do ILM peeling until unless it's required in cases of epiretinal membrane. Uh, if the visual acuity preoperatively is bad, CME is there, then you have a bad visual prognosis. Idiopathic epiretinal membranes has a better visual prognosis as compared to a non-idiopathic epiretinal membrane. If you have an good integrity of ES ellipsoid zone on OCT, and you will have a good postoperative visual acuity. Uh, if the parallelism more parallel the retinal layers, the better the visual acuity. So you should identify what Dr. Ritesh was telling. Drill. If you have drill, then the visual improvement will be less as compared to no drill patient. You can have intraoperative complications like vitreous hemorrhage, peripheral retinal breaks, postoperative complications like nucleus sclerosis, RD infection, and recurrence in 5% of cases. One of these patient, I landed with a major complication. You can see here an epiretinal membrane here. I didn't find a edge, so I thought I should go ahead and stain this under an air. So once I am staining and removing this retinal dye, you can see this mound coming here. And after removing the air, I realized that whole of this retina, because of the fluid air exchange, has ripped from the edge of the buccal, and there is inferior detachment in this patient. And this patient, I completed the vitrectomy, created an edge of the epiretinal membrane, and once the edge was created, I peeled this membrane, and this retina, inferior retina, is now detached. So lucky for me, I removed the membrane in toto, and it came in toto. Then PFCL was injected, vitrectomy was done, laser was done to the periphery, and instead of air, we had to fill this patient with oil. And you can see this whole of this area here, this has ripped. So to, to conclude, advancement in instrumentation has made macular surgery the most sought after surgery in retinal surgery. Uh, and ERM at the moment is the most preferred surgery for the retinal surgeons with good visual results. Thank you very much.
Excellent videos, Dr. Gupta. When you have a post VR surgery membrane, and let's say the oil is in the eye, but there is now a membrane forming a few weeks later, and it is affecting the vision also. You can see the deterioration. How do you handle it? Do you remove the oil even if you don't otherwise want to remove the oil? Would you remove the membrane with the oil, leaving the oil inside, or would you remove it?
Uh, it depends on what kind of situation. If it is there is a detachment, or there is an some break, secondary breaks, then you intervene immediately. Uh, if there is an traction and only epiretinal membrane under the oil, I'll prefer to remove the oil and do an ERM surgery simultaneously and leave the eye under air only. And I generally prefer to remove whole of the oil, then go in for an epiretinal membrane. I don't prefer to do it under oil.
But sometimes you don't want to remove the oil because there is an inferior break which is open, it is on the buckle, it is lasered, but you are not sure that without the support of oil there will not be a redetachment. That's
Then
a,
it becomes a resurgery kind of a thing.
so in these cases, I think what I would do is, and I do it, is remove the membrane but leave the oil in. And those patients are very happy because the macula improves. So it can be done. But I think it's better to stabilize the membrane with a periocular steroid in these patients. It helps to make it a little more, consolidated and easier to remove.
Yeah, that's what if the membrane is very thin and flimsy
You can try
membrane,
to
don't go
avoid it,
ahead and
yeah.
operate. Just wait for two,
Wait.
3 months, let the membrane mature and then go in
Yes,
for the
yes.
surgery.